Let's imagine the knee is swollen. What could be the problem? Is there an articular lesion, a ligamentous lesion, tendinous lesion? Well, further examination is going to reveal that. But perhaps an interesting general remark. When the patient has a rupture of the ACL or the PCL, the knee can swell indeed, but we don't expect too much swelling. And the reason for that is that those cruciate ligaments, they lie outside the synovium. And if you compare a rupture of ACL with an acute MCL lesion, then the MCL lesion, the medial collateral ligament, is going to provoke much more swelling. When we see a lesion of the MCL, then we have to palpate three different localizations. There could be a problem at the joint line, the femoral part, and the tibial part. Mostly the problem lies at the joint line. This ligament is also pretty long, pretty thin, pretty broad in comparison to the lateral collateral ligament, which is really harder, shorter, and rounder. Now, that ligament feels like a tendon. That ligament lies also more posterior in comparison to the MCL. And then we have another interesting structure, the coronary ligaments. Depending on the atlas in which you study your anatomy, in Gray's Anatomy they talk about coronary ligament. The right picture is coming from Sobota, and there they talk about capsula articularis meniscotibialis. But perhaps this is an interesting structure that perhaps sometimes is forgotten a little bit. This is one of the first structures which is lesioned when the patient has a flexion rotation trauma. Okay, before we really examine the knee, then question number one is always that knee pain. Is it coming from a local problem or is it referred? And let's imagine that a patient has anterior knee pain. Well, in that case, it could be referred from the spine, it could be referred from the hip. If the patient has posterior knee pain, well, it could also come from the spine, but it can also come from the sacroiliac joint. So the history will put you in the right direction. And then there's another important detail. After articular or ligamentous traumas, then in the knee there is a kind of post-traumatic capsular reaction that becomes dominant. So in other words, actually you will see the image of a kind of an arthritis. You will see a kind of capsular pattern with swelling, but this in fact is superimposed on the actual ligamentous lesion, let's say an acute MCL lesion. More about that a little bit later on in another lecture. Actually, this also happens in the foot, when you sprain your ankle. But in the knee, this is really clear and pretty dominant. So, moral of the story, you really have to listen carefully to the story and perform all your tests. Okay, so first we do a nice history taking. But before the history taking, we also open our eyes and let's have a look at the inspection. And what can you see? Well, you can see some local swelling that could be the result, for instance, of some kind of exostosis, or perhaps a very nice older Osgood Schlatter, which in that case at that age is pretty asymptomatic. Or there could be a kyst, or there could be an inflamed bursa. But the question is, if the patient has a pretty swollen knee, is that related to synovial fluid, or is it more blood? Well, if it's a synovial swelling, then the swelling, let's say, moves like water. Yeah, we have different tests in the examination for swelling, and then you can see, you can play a little bit with this swelling. But more important, there was a trauma, and the swelling is coming later, not immediately after the trauma. Perhaps the swelling is coming 1 hour, 1.5 hours later. Remember the post-traumatic capsular reaction. If we talk about blood, then the swelling appears much more quickly. A few minutes after the trauma, the knee is swollen. And of course, that could be a risk, because if blood is not aspirated, we could develop a severe arthritis and also erosion of the cartilage. But I also must say that the points of view on aspirating blood are differing a little bit. Have therapists who really would like to do that. Other therapists say the risk is too high to develop infection. So I leave it in the middle. But it's important for us to know if the swelling is blood or just synovial fluid. How old are you, and what exactly are you doing in your professional and private life? Which sports do you perform? Which hobbies do you have? And if there was a trauma, what exactly happened? In which position was the knee during the trauma? Of course, that's not always very easy to remember, but was it a valgus position, a varus position, extension, rotation? If it's a valgus, your first idea is MCL, varus, LCL, extension, perhaps cruciate ligaments, rotation, perhaps coronary ligaments. Is there any feeling of giving way, locking, twinges? Well, when you hear those elements in the story, then this is typical for an internal derangement. And then the age is actually also playing a role, because when you hear the internal derangement story, and the patient is, let's say, 14 years old, your first idea is going to be osteochondrosis dissecans. When the patient is 25 or 30 years old, first idea is a meniscal problem. As from 60 years old, the first idea is a loose body in an arthrotic joint. It's 3 times exactly the same story, but because of the age, the problem might be different. Where exactly is your pain? Is it the whole knee? Is it more the medial, the lateral part? Is it inside the knee? Is it suprapatellar, infrapatellar? Important to know, is there any shifting pain? The patient says, yeah, I have pain there at the medial side of my knee, and your question is, does the pain always stay there? And then the patient says, actually, no. Sometimes I also feel it a little bit in the posterior aspect, sometimes a little bit anterior, but mostly medial. This is a shifting pain. And a shifting pain is a shifting lesion. So what can shift in the knee? That's going to be an internal derangement. So you can think again of a meniscal problem or a loose body. We just talked about swelling. So how fast is the swelling coming? Slow onset of the swelling, synovial fluid. Fast onset of the swelling, blood. And then something very important. Imagine a football player. He has a flexion, a lateral rotation trauma. has a lot of pain. He lies on the ground. What is his problem? Does he have a real acute meniscal problem or a ligamentous problem? Well, if he has a severe meniscal problem, immediately after the trauma, his knee is blocked. The game is over. The knee is blocked. Yeah, he can't do extension anymore. And he has to stop the game. If the patient has a ligamentous lesion, then it's quite possible he can continue playing with pain. But after the game, the post-traumatic capsular reaction is setting in, and then he gets swelling and the presence of a capsular pattern, limitation of movement, so he gets the functional problem sometime later. So that's a clear distinction in the history. Is there any radiation of pain? In the calf, for instance. That happens with people who have a Baker's cyst. Yeah, more about that later. Is it the first time you have this problem? Did you get treatment before? Which kind of treatment? What happens when you go up and down stairs? For instance, a patient with a beautiful quadriceps muscle problem, he's not going to like to go up and down stairs. It's painful. But, for instance, an elderly patient with an arthrotic knee who has the story of an internal derangement will also say, well, I have a certain instability feeling on going downstairs. I have to go step by step because I don't trust 100% on my knee. I have the feeling I'm going to lose control over my knee. Another element to think of internal derangement. Okay, before we do the functional examination, where we're going to palpate for heat, I would like to know if the knee feels warm, yes or no. And then we go to knee flexion. We go end range. The end feel is elastic. The end feel of extension is hard. Then we build in 90 degrees knee flexion, dorsiflexion in the foot, and we go to lateral rotation. We go to the end and we slightly provoke, and this is going to be the main test for the medial coronary ligament. We change the position a little bit for practical reasons, and then we go to medial rotation and we test the lateral coronary ligament. We build in a little bit of flexion. Then we take up the slack, we go to valgus, and then a nice provocation, of course, the test for MCL. And then we change the position of our hands and we go to varus, the test for LCL. Important, build in a little bit flexion in the knee, because if the knee would be in full extension, then the knee is locked and nothing will happen. The anterior shift, a so-called test for the anterior cruciate ligament, but unfortunately that doesn't seem to be a very reliable test. The good news is we have better tests. For instance, the Lachman is a better option. Now we compare left and right, and we are not looking for pain. We are looking for hypermobility. Okay. I came across this interesting article where a colleague tested if we can do the Lachman test also from a prone lying position instead of a supine lying position, and well, the results seem to be very promising. But the author also focused on a very important detail. The test should not be used as the only criterion to rule out an ACL rupture. And here I come back again with my famous word, the package. Yeah, we are always looking for a combination of positive signs and negative signs, and the elements from the history, the elements from the inspection. All those puzzle pieces together are going to give me a nice image. Another test for cruciate ligament could be the Lelys test. I advise you to go on YouTube, just look it up on YouTube, and in fact it's a very funny test. This patient had a complete rupture of ACL, and if the doctor is pushing on the femur down, then in normal circumstances the foot should go up, but now the foot just stays on the table and nothing happens. A nice test. Posterior shift, you palpate in the joint line and then you do a posterior shift, and with your thumb in the joint line you are looking for hypermobility. And then we have some resisted test, resisted extension in relation to quadriceps, of course, resisted flexion, the hamstrings, and then a few tests for swelling. And finally, a palpation at the medial condyle for synovial thickening. We could find a local swelling over there in case of some active rheumatoid problems. A Baker's kyst could cause quite a severe swelling in the calf, which is illustrated on this very old picture, but it's still spectacular. But why do I like to show you this old picture? Because there's also something else in the yellow circle. Have a look at the subtalar joint, and you see that the subtalar joint is in valgus. And if you already watched the lecture on the examination of the foot, then you remember that a heel which is fixated in valgus, where the varus disappeared, this is the capsular pattern of the subtalar joint. This is a patient with also a very beautiful arthritis in the subtalar joint. If necessary, we have some complementary tests. For instance, a squat movement, and at the same time we palpate the knee in relation to patellofemoral arthrosis. Or we check the lateral rotation again, but this time from prone lying position, and we do it bilaterally, and that will allow us to detect visually a nice hypermobility. For instance, if the patient has a complete rupture of the MCL, then it's quite possible that the lateral rotation also will be quite hypermobile. And of course also the valgus. We can combine resisted flexion with medial rotation or lateral rotation. And in this way we can distinguish a little bit between a biceps lesion or a popliteus or a pes anserinus lesion. Popliteus and pes anserinus are medial rotators, and the biceps is a lateral rotator. And then there are also a number of meniscal tests. For instance, here we palpate in the joint line, and then we move to lateral rotation, and from that position we move to extension and back to flexion, and we feel if something moves under our finger, or we hook in the joint line and try to hook the anterior border of the menisc. Well, to be honest, in my career I felt this only once, and it has been confirmed later on during the arthroscopy. But we have to be honest, most of the meniscal tests don't have a good validity. It's quite possible that a meniscal test is so-called positive, but there is no problem, and it's also it's also possible that a meniscal test is negative, but there is a problem. So be careful with those tests.